multiple lesions, and look at this lesion here, and look at this one. And this is the rib, which is fibrous dysplasia at the base of the skull. Again, this is a SPECT, nuclear scan, which has got uptake there. This sign in literature is known as pirate sign. You can make out a pirate, you see this. So pirate sign. So this is sphenoid wing. And this is again from literature, from Mayo Clinic. And this patient is interesting, where this is a PET scan, by the way, where the patient has a known breast cancer, and they were worried about what's happening in the spine, and ultimately it showed uptake on PET, and ultimately it proved to be fibrous dysplasia. Point I'm making is that nuclear scans, maybe PET, maybe SPECT, maybe normal bone scan, they do come for polyostotic fibrous dysplasia, and keep your minds open for that. So, okay, now we have got another 5-minute break, and when we'll meet up, that will be the last component of So can we have number 11, please? If number 11 is with us?
Yep.
Okay. So over to you. How would you describe this?
So this is a frontal pelvic radiograph for a 2-year-old male. The bilateral femoral epiphyses appear sort of slightly stippled in appearance, with irregular margins and some loss of height on the left. There's also possibly an associated effusion on the left-hand side. No other abnormality is seen. My primary differential for these appearances would be avascular necrosis.
So avascular necrosis means Perthes disease. Should you consider it at 2 years of age?
Probably not.
Yeah. So what's the age for Perthes?
Older, but I can't remember off the top of my head.
Yeah, 4 to 8. So anything else comes to your mind other than Perthes?
No.
Okay, that's fine. So if you see here, this is the differential diagnosis of irregular or stippled epiphyses. Normal is a spectrum. avascular necrosis, please remember that they can be bilateral in 10%, but the age group is different, not less than 4 to 8, 4 to 9, that's the age group. Congenital hypothyroidism or cretinism is a very important one. And you should always remember that Marcus as mucopolysaccharidosis, this is important. There is an entity, we call it multiple epiphyseal dysplasia, which the name tells you that the epiphysis will be abnormal. Mears dysplasia is the same thing, but this one only involves femoral capital epiphysis. So the case there was actually Mears because the other epiphyses were absolutely normal, but nobody is expecting you to just say Mears on this. But for discussion, you have to know this differential. I use the word discussion cases. They are coming in FRCR more commonly these days. Discussion cases are cases in which there is a bit of what we call a discussion about the case, but there might not be a specific diagnosis. These are the kind of cases in which when the candidate comes home, they think that they have not been able to satisfy the examiner. But it's not like that, because there was no obvious, discriminator on that case. So this is a discussion type of case. This is just for your differential, I am showing you this. That in this case, epiphyses are abnormal, but other epiphyses are also abnormal. And this is a dysplasia, which is multiple epiphyseal dysplasia. Okay, over to you.
This is a frontal and lateral radiograph of the lumbar spine for an adult patient. There is a scoliosis to the left with loss of height in the L1 and L2 vertebral bodies. On the lateral projection, the vertebra demonstrate posterior vertebral body scalloping and some irregularity of the posterior elements. I think that's the main abnormality that I can see.
So what is your conclusion?
So in summary, there is posterior vertebral body scalloping and likely a secondary deformity in the alignment of the lumbar spine. My differentials for this would include a neural-based pathology such as neurofibromatosis.
Okay, so can I stop you there? So you are considering neurofibromatosis because of the posterior scalloping, fine. But let me give you a hint. Look at the pedicles.
So they're thinned. Or flattened, rather.
Something else.
Are they quite widely spaced?
So your thinking is correct, and so slight bit of fine touch is needed. Spacing is what we are talking about. Is the spacing normal or abnormal? This is the discussion.
So this.
So if you see the distance between this pedicle and this pedicle.
Yeah.
This is this pedicle and this pedicle.
Yeah, so it gets progressively narrower as opposed to getting progressively.
So have you got your diagnosis then? Can everybody please switch off the mics, please?
Would this be in keeping with achondroplasia?
Right. So, same case. Anything comes to your mind? By the way, what did you say? I did not hear your conclusion. What did you say? Did you make a diagnosis?
I asked if this would be in keeping with achondroplasia.
Oh, yes. Okay, so you've got it. So let me tackle it. If you see in achondroplasia, what happens is the key exam finding is that the interpedicular distance normal is that as we go down from the lumbar to the lower lumbar spine or the sacral spine, the the interpedicular distance increases normally, and it is other way around in achondroplasia. That's a key finding to diagnose it. It can have posterior scalloping. These are secondary degenerative changes. We know that in achondroplasia, secondary degenerative changes will occur. This per se is a very, very good exam film where what you can see is that there is a what we call a tombstone appearance of the iliac wing, and with that epiphyseal abnormalities, etc. Champagne glass pelvis is the shape. But if you look carefully, again, look at this pedicle and this pedicle. Look at the distance from this to this. And then look at the distance from here to here. Look at the distance between these two. And you can convince yourself that it is decreasing. So this kind of subtle finding, but you get your diagnosis on that. Achondroplasia. Now, posterior scalloping of vertebral bodies is an extremely important exam film. Very, very, very important. If you look at this differential diagnosis, tumors in the spinal canal is one. Tumors in the spinal canal is one. Then is neurofibromatosis, acromegaly, achondroplasia. So I just want you to remember these ones. And we will see a few examples about this. So in achondroplasia, it can happen, posterior scalloping. Okay, can you please once again take over and describe this case for us?
These are frontal and lateral radiographs of the lower thoracic and upper lumbar spine for a 19-year-old male. There is long segment spinal instrumentation through the posterior elements. There is also a scoliosis of the image portion of the spine. On the lateral radiographs, we can see posterior vertebral body scalloping with enlargement of the neural canal. And likely secondary degenerative changes to the abnormal alignment of the vertebral bodies. These appearances would be in keeping with a chronic, possibly congenital disorder.
Like what?
So
the differential. This was the differential.
Yeah, so the differentials again would include achondroplasia.
No, in your case here, you have got scoliosis. You have got long segment. So this patient had scoliosis and long segment instrumentation. Then you have significant posterior scalloping at multiple levels.
Yeah.
So, and by the way, you can see the pedicles. Pedicles are not, decreasing in interpedicular distance. So, what is the conclusion then?
So this is a chronic condition.
No, okay, among these four, pick up one thing.
Could this not be neurofibromatosis?
Okay, very good. Okay, well done. Now, I'll take over. You can mute yourself now. And next, if number one is with us, I'll ask number one. But let me first of all tell you about this case. Now, neurofibromatosis is one of the very, very important cases for the exam. This is the definition of neurofibromatosis 1 and F1. And this I'm going to tackle in detail when we are considering CNS. Look at these 7 points, and this is the definition. If a patient has got 2 or more than 2 of the following, you call it an F1. The first 4, which are in white color, are not for us. The clinicians are going to tell you this. K-foliar spots, axillary freckling, Lish nodules, which is iris hematomas, or first-degree relative. So these are all for what we call the clinicians to tell you. But 5, 6, and 7 is where radiology plays its role. Neurofibroma, 2 or more, or plexiform neurofibroma. So we will see all of these things when we do CNS. Optic nerve glioma. Look at this distinctive bone dysplasia. And please remember, earlier today when we did see the pseudo-arthrosis of the tibia, that is what can happen in NF1. Then there is what we call dural ectasia. Bare orbit, we will see it in CNS or head and neck module. But dural ectasia is what you were looking at. In dural ectasia, what happens is, it is ectatic dura, simple as that, which can cause posterior scalloping. And sometimes I'll show you later on these films in CNS, where, they are synonymous with the term pseudomeningoceles. There can be also laterally, they might be going lateral into the neural foramen. And you have to discriminate. Please remember that in neurofibromatosis, there can be just dural ectasia causing the posterior scalloping. And in other cases, there might be some tumor also, as in a schwannoma or a neurofibroma sitting there. So both of these can cause posterior scalloping. Okay, thank you. Is number one with us? If yes, then say if you can acknowledge.
Yes.
So, this is my favorite film, absolutely favorite. So, good that you got this. It's a very, very, very good case. Film. Over to you.
Okay, so this is a frontal radiograph of the lumbar spine. Okay, so there's no scoliosis. On this frontal view, the vertebral body heights are normal. I'm just looking to see the pedicles, which I'm finding difficult to see on this AP view. Yeah, I can't see any pedicles at all. And the transverse processes are present. So, in summary, this patient has clearly a congenital condition with absence of the pedicles in the lumbar spine.
Okay, so let me show you a lateral.
So on the lateral view, there is posterior scalloping of the vertebral bodies throughout the lumbar spine. As seen before, there are no pedicles. And there's some sclerosis on the posterior elements. And the spinal canal appears to be widened. So possible causes for this would include durolactasia, and if that's the case, this could be part of neurofibromatosis type 1.
What else? Okay, what else other than durolactasia?
So I don't know.
Okay, let me take over. So your findings are correct. Basically, if you see this AP film, what is happening? If you look at this pedicle and this pedicle, they are actually compressed, and the interpedicular distance from here to here is slightly increased. But this finding is present here, 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 here. And if you look at the lateral, look at this pedicle, you see the pedicle here, you see the pedicle here, and you don't see the pedicle. Why don't you see? Because they are thin, because of radiographic factors. They are so thin that they give you this pseudo appearance as if they are not present. With that, you see this posterior scalloping. Something is sitting inside. Something big is sitting inside. And you talked about durolactasia, and your hypothesis is that whole of the dura is, sort of ectatic. Okay, fine, I will take that. But having said that, this is a spinal tumor. And this is another case, not the same case, because I don't have a cross-sectional imaging for the previous case, but this one tells you what happens. This is an exam case once again. This is what we call a myxopapillary ependymoma, or the phylum terminal or conus ependymoma, in which ependymomas are grade 2 tumors. They are long-standing. One of the key findings is visible here on this T2 weighted sequence, that there will be hemosiderin deposits, which is blood, chronic blood, which will be low signal on T2. But look what is happening, because it's sitting there for ages. It is doing posterior scalloping. Now look at these axials, and this will tell you what happens. It is sitting within the spinal canal, and it is causing, this. You can see that this pedicle is thinned out. So the previous case was similar example. So this is, the differential of posterior scalloping tumor in the spinal canal. So this was a tumor in the spinal canal. And there is another differential in your book, which is widened interpedicular distance. Myelomeningocele is one, but intraspinal mass, diastematomyelia, these are the ones which can cause widened interpedicular distance. Yes, please.
Okay, so this is a frontal radiograph of a hand and a lateral spinal radiograph of a 2-year-old female who's short for age. So on the lateral spinal radiograph, there's an abnormality in one of the vertebral bodies within the lumbar spine. It looks like the L2 vertebral body. It's got a shortened anterior distance. Looking at the radiograph of the hand, there's an abnormality at the distal radio-ulnar joint with some erosion of the medial surface of the ulna.
What's happening to the metacarpals? Is there a pattern to that which can help?
So the metacarpals are a little bit elongated and widened. And yeah, they're just shaped a bit abnormally.
This appearance, what do you call this appearance of a vertebra? You see the anterior, this thing?
I don't know. So.
Right. Now, if you look here, this gives you a proximally tapered. If you see these metacarpals, you will appreciate that they are slightly more thicker here, and proximally they are tapered, right? So this is a congenital abnormality, which is again an exam abnormality, but this thing is the key which you have to pick up. So this is the pelvis of the same case. Anything comes to your mind?
So there's what diastasis of the pubic symphysis?
Not really, but you've got a point that the distance might be slightly increased, but there are so many other things happening. Can you put everything together and give me a diagnosis? If you see these femoral capital epiphyses, they look to be slightly stippled.
Yeah.
At the pelvis, it is narrow. And this pelvis, by the way, in description is known as the simian type of pelvis, ape-like pelvis. So all of this together, what is the diagnosis?
I don't know. So.
No. Okay, that's fine. Don't worry. So this is mucopolysaccharidosis. Mucopolysaccharidosis is a spectrum. There are 6 types which are described, and Morcus is type 4. And these patients are mentally normal, and at times they are diagnosed on radiology, by the way. And at times what happens is that as the baby is growing, they might look fine, and they might be diagnosed after 3 or 4 years of age. So that is the only type of mucopolysaccharidosis which is important. Key findings for the exam is, the vertebrae. The vertebrae will be abnormal. They can be bullet shape, as in this one, bullet shape. And there can be beaking, anterior beaking, which can be at the inferior edge or middle portion. And there can be various other, non-specific findings. Epiphysis will be abnormal, metaphysis. The long bones can have this tubular appearance. You got it right, that there might be subluxations here. There can be simian pelvis. With that, there will be fragmentation of the epiphysis. So please remember, it will also come in the differential diagnosis of, that stippled epiphysis. You remember we did a case in which both femora had stippled epiphysis. So it will come in that list also. Another finding, this is another patient. I showed you another patient. One of the findings which is in literature is this one, that the metacarpals, they have got a the proximal ends are proximally tapered. You can imagine that this end is tapered and the distal end is flared. So this is mucopolysaccharidosis. Before we continue, we are just finishing in another 15 minutes or 10 minutes. Have we got with us number 14?
Yes, hello.
Okay, so number 14, you are next, and thank you to number 1. So I have given you the diagnosis in this case, but just as a practice, can you give me the findings? Can you describe the findings? Because this again is an exam case.
Right. On the middle image, it's a frontal projection of the lower dorsal and lumbosacral spine, and showing the upper pelvis as well. I can see that there is progressive narrowing of the interpedicular distance, particularly within the sacral vertebrae. Also, the pelvic bones are abnormally shaped. They have the characteristic tombstone appearance of the iliac bones bilaterally. On the lateral projections, I can't really see full details within the whole spine image, so I just comment on the zoomed image. There is abnormal bullet-shaped vertebrae with decreased height and shortened pedicles as well. I can't see any other abnormalities.
Excellent, well done. Good.
Thank you.
So what I wanted to show in this case, that this anterior beaking of vertebra, please remember, beaking can be in the central portion, beaking can be in the inferior portion, which was the last case. You see this beaking here,
It's inferior.
Not specific just for one thing. It can happen it can be seen in achondroplasia. It can be seen in what we call mucopolysaccharidosis. So that was the main point here.
These are CT and MRI images of the spine. Within the CT images, I can see sagittal.
So, excuse me, these are 3 different cases. So you can describe 3 different. Just confine yourself to this one, then this one, then this one.
All right, I'll start by the far right one because it's the obvious one.
Okay.
There is this looks like epidural distension or neurofibromatosis, causing posterior scalloping of the lower lumbar and sacral vertebral bodies. Within the middle images, these are T2 and T1 sagittal images. I can see a well-defined intramedullary lesion causing expansion of the distal spinal cord. The cord also seems to be terminating early. It should be far downwards than this. I'm not sure if it's because of the image. The intramedullary lesion is causing focal posterior scalloping of the adjacent vertebral body. On my normal practice, I would arrange for contrast images for this lesion for better characterization, but based only on these images, my differentials would be an intramedullary neoplastic lesion. This could be an ependymoma or astrocytoma. I would also like to review the axial images just to make sure that it's an intramedullary lesion. There is another option that it would be an extramedullary intradural lesion. The far left images, the CT images show a lytic lesion within the right pedicle. It is causing bony expansion and shows a thin sclerotic margin. This is also for differential diagnosis. On the top of my differentials would be a chondroblastoma. Yeah, that's all I got.
Okay, so a bit of fine touch. Now, this is a case of dural ectasia secondary to NF1. You got all of them, you got it right, but the only thing is in the description, what I wanted to show you this and show you this in one slide. Here, this associated tumor, right? You have to mention it as a pertinent negative, that it is not associated with a mass. You remember that myxopapillary ependymoma, which I showed you, that was giving you the same appearance. And
Yes.
And this, you remember this thing? See this thing?
Yes. Yeah, it's almost identical.
Yeah. So in your pertinent negative, we use the word pertinent negative in the exam. You have to tell the examiner that there is nothing else. This is just CSF intensity, and this is in keeping with dural ectasia. Here, something which you brought a smile on my face at 9 o'clock, because your last sentence in the description should have been your first.
All right.
You see, why did you jump to the conclusion that this is intramedullary, right? And first thing you have to is confirm that this is intramedullary, and for that, correlation with axial is critical. You cannot make a diagnosis because a intradural extramedullary lesion might be sitting here, and this is, by the way, it is not intramedullary, it is intradural extramedullary. It is pushing the cord and giving you this pseudo appearance. So that is the learning point in this case, that you have to ask for axial in the beginning. I would like to see the axial, describe it, and then tell the examiner that I want to make sure that it is where it is. And it was, this is, the differential will be a schwannoma or a neurofibroma.
Yeah.
This case, again, it is similar to this case, but this is a CT scan. It is not the same case. And it is also schwannoma slash neurofibroma. Of course, you don't have evidence more than that. Okay, all right. Actually, this was the last case of the day.